Good evening, friends. Welcome again to the IAP PG Clinics broadcast. And today we have a very special surprise for you. We have Dr. Vrajesh Udani, who's going to be our guest faculty. And it is my view, he's the best pediatric neurologist in the world. So we are going to have a great evening today. That's my view, sir. I'm allowed to have my views. A few announcements before we start. To the audience here, when you want to speak, please ask for the mic and then speak into the mic. You need to be audible. To the people watching online, please send in your questions if you have. There is a lag of about 2 minutes between the clinic here and what you receive there. So your question will be answered, but it may take some time. Sorry? Faculty. I don't think I need to tell you guys. Okay. The next broadcast is going to be on the 11th of February from Kanchikama Koti Children's Trust Hospital, Chennai, and it's going to be from 2:30 p.m. onwards. Those of you who miss the live telecast can always visit the page and see the left-hand side panel where the past clinics are there. You can click on them and watch them. So, without further ado, let's begin today's clinic. Dr. Prajna, please come.
Sneha, 2.5-year-old girl child, second by birth order, born of non-consanguineous marriage, resident of Sion, hailing from Surat, Hindu by religion and informant being mother, came with the chief complaints of fever since past 4 days, cough since 3 days and breathlessness since 1 day. Child was apparently alright up to 4 days back when she developed fever which was mild to moderate grade.
How old, sorry?
Yes, sir. 2.5. Not associated with chills or rigors, intermittent subsiding with medication. Cough was wet type, non-spasmodic, intermittent, not associated with post-acid vomiting. Breathlessness was in the form of increased rate of breathing and increased chest movements as noticed by the mother. For these complaints, child was admitted, started on IV medications. Breathlessness has now subsided, and fever and cough have reduced since after 3 days of admission and IV medication. There is no history of associated cold, no history of cox or cox contact. There is no history of previous admissions or similar episodes in the past. There is a significant past history in that child was taken to a doctor in view of not being able to sit up on her own till she was up to 10 months of age, for which she was investigated.
Can you please tell me what do you mean by sit up on her own? If she was made to sit, she could sit?
Yes, she could. Yes, sir.
So what age was that?
That was around. She could roll over and all, but she was not able to sit up.
Don't tell me the developmental history. Okay, sorry.
Investigations included CT brain and.
I prefer not to talk about the investigations. Just say she was investigated.
She was investigated for the same, and mother also gives a history of significant weight loss since that period of time till up to now. In birth history, child was full-term normal vaginal delivery, hospital delivery, 3 kgs of birth weight. There's a baby cried immediately after birth, but cry was weak. Activity of the baby was good. She was breastfed within an hour of birth and was discharged by the very next day. There is no USG was done during the antenatal period twice after the 5th month. Quickening was felt, but mother does not remember exactly when. Injection TT was taken and folate supplements were taken by the mother. Developmental history. Gross motor milestones. Child achieved neck holding by 4 months of age. She could drag herself forward on her abdomen by 7 months and could could roll over by 7 months of age. But she was not able to walk on all fours.
Now, what about sitting? If you made her sit, when did she achieve sitting balance?
She could not sit on her own. If you made her sit, then she could sit by around 11 months of age.
I see. How do you look at sitting? How does it start and how does it progress?
The child can sit.
So what is the earliest sitting you achieve?
With
and approximately what age?
With support around.
Support where? Anybody can answer. So what kind of support do you need? What kind of support does a baby take when she starts sitting?
Sir, upper trunk, he needs just a support from the back to maintain the posture.
No, but she's sitting independently. I'm not talking of you put her back against a wall and she's sitting. I'm talking about sitting independently with her body, with her using her own hands for support. So what do you see?
Tripod means keeping the hand.
So anterior propping. You put your hands forward like this, and that's how you sit. At about 5 months, give or take a few days, 15 days here or there, 5 months, 5.5 months. What is the next stage?
Sitting without the support.
Yeah, so what do you need to develop before that? Lateral propping. So what does lateral propping mean? How do you test for it, or what is its reflex? So if you have a baby who's kept like this, no, it's okay, anterior propping, and you push the baby from one side, the hand won't go automatically. That's at 5 months. But a little later, the hand will prevent her from falling, him or her from falling. And once you develop lateral propping, then you have sitting without support. Okay, the back should be straight. What is the next step in sitting? So that occurs around 6.5, 7 months. Of course, it's a little different in all children, and you might find it in little variants in different ethnic groups, but generally. What's the next one? What is pivoting?
Turning while sitting, child turn to the one.
Yes, it's on.
While sitting, child turn to the one side.
Correct. So now this balance is improved, and the baby can now turn around and get something which is behind her. So remember, around 7 months, the baby gets what is called object permanence. So now she knows that, or he knows that, there's something behind her. So you show her a toy, you put it behind, she turns around for it, and by about 8 months, 7, 8 months or so, she can turn, or he can turn and get everything what he wants. So he pivots very well. And then you come to crawling, which you were talking about. Now what is getting to sitting? So from without aid, the baby gets up. And that occurs after the initial part. So initial part, you are made to sit and you sit. Later on you get to sitting. That I'm not sure what exact age it occurs, but I would say by 8-9 months. 8 months, 8.5 months. Around the time of pivoting, the child gets to sitting. So it's very important, when you have this symptom of sitting, getting to sitting may not be attained at all in which diseases?
SMA.
So, SMA, straight. So, neuromuscular disease. It indicates truncal weakness, neck weakness, truncal weakness. So that's what I'm trying to say. Getting to sitting is a very important. You may not be able to, SMA child, for example, using your term, say SMA type 3, may be able to walk, or many myopathies, may be able to walk once you make him stand and walk. But he can't get to standing. The same way he can't get to sitting by himself. He needs help. And that's a very important sign. So, delayed sitting could be seen in brain diseases, muscle diseases, nutritional diseases. Everything can be a little delayed. But getting to sitting is a very useful milestone. Okay. So we don't know. You're saying she can't get to sit even now?
No. Now the child is 2.5 years. She can still not get to sit.
So what's happened to the other milestone?
Rajesh, I have a query. There are some babies who are capable of sitting when made to sit, but they can't get into that position just because they are not able to crawl on their fours. Some babies have just not learned to crawl on their fours, though they are otherwise alright. So they can't get into that sitting position at all.
No, crawling is an optional milestone. Many children may not crawl at all. But crawling is something which you do prone. Getting to sitting, you do supine. So that is a different thing altogether. You see, in fact, this is a very important sign all through all neuromuscular diseases. Even when they are older children, say a Duchenne muscular dystrophy, the first thing which is weak is the neck muscles. I always tell my residents that. So the first thing you do is you make him sit. And they cannot sit, the head doesn't come along with the body. There's a slight lag. And many of them, in fact, even take a little turn, or they use the support of their elbows or something to get to sitting. So that is a very useful sign, especially if it's isolated. Obviously, if you have all other milestones also delayed, then you can't see anything. It may be a generalized process in the brain also. You may not be able to get to sitting. But if everything else is achieved nicely, then getting to sitting, getting to standing, which of course is one way of looking at the Garver's sign. What is Garver's sign? It's getting to standing from a squatting position. So yours, because it's very difficult to test all these muscles in babies. You can't do, muscle testing. So this is a very useful way of finding out.
That is in a fine motor, the child had started to develop pincer grasp by around 9 to 10 months of age.
Much before pincer grasp.
Palmar grasp, but by the
how she's 2.5. Okay, most mothers and fathers are not going to give you. How do you ask about pincer grasp? What do you ask? What is the question you ask the mother?
If she can hold objects with her thumb and index finger. So they generally say she can.
So that's the question you ask. Would anybody ask differently?
Could she pick up a grain?
That's right. What do you pick up?
So,
you pick up something big, I don't think the parents are that observant that they're going to see whether the index finger and the thumb is used. But you cannot pick up a grain without using your index finger and thumb only. It's very difficult to pick up a grain like this or with the, thumb finger grasp or 2-finger grasp or whatever. You need a pincer grasp. So now that is a very difficult thing to remember. When did your child start picking up grains? So when you ask the history, the later you are in your life, the most simple question should be asked for them to be accurate. If you keep asking, they will say something and you will say it in your exam over here.
In fact, in the same way, we didn't understand whether this child is now just able to sit or can do something.
Yeah, is he walking?
No, sir. He is not able to stand without
So you
support.
need to make that
The
clear.
last gross motor milestone that
No,
he has
because you
achieved.
moved to fine motor. I'm sorry, I missed that. You did not talk about what happened to him. Is he standing with support?
No, sir. No, the last gross motor that he has achieved is if you make him sit, he can sit. Other than that, he cannot stand with support.
He can't hold a table and stand?
No.
If somebody holds him also, he can't stand?
No, even if you hold him, he does not put his...
so there's something called supporting weight on legs.
He does not support his weight on his legs. Even if
When does that occur?
That occurs by around 6 months. Okay.
4 months. By 5 months, 4.5 months, the kid is going up and down, playing with you. All the mothers are nodding their heads. Yes. So I think that's an important thing. So that's clear evidence that at least there's significant problems in gross motor. So fine motor, you said, what about when did he start reaching out, playing with toys, eating himself, holding the bottle if he ever held a bottle, or whatever, taking a biscuit?
Reaching out and all, she does not remember so much. But feeding...
But thumb and pincer grasp she does remember. That's interesting.
But then she said, when you give him anything to eat, he picks up like that and eats. So that is when I asked her at what age she started.
Okay, fine. Go on then.
Patient, she can hold a pencil and scribbling. She's able to scribble, but other than that, she cannot.
What would you want her to do?
Scribbling is well enough.
Okay. So scribbling occurs at what age around?
For
Anybody can
15 months.
answer.
15 months of age.
1.5 years.
Yeah, so 1.5 years is fine. So around, the ones who are more motivated parents will do it earlier. So yes, but 1.5 years is average. Then?
And language. Child started saying combining syllables, calling out mama, and at around 7-8 months of age. And
what do you think that is? What is now we are into? We finish your language and then we'll talk about language.
at present, child.
So she started. You are saying mama and all at 7-8 months of age,
8
and
months
then
of age. She can. She could understand spoken commands.
Okay.
By,
If you don't have it, just say I don't know. But
and
okay,
at
let's.
present, she can.
At present, yeah. She's
by
2.5,
by,
right?
By around 2 years of age, she could. If you ask her like body parts, where is the nose or something, she could point to it.
Excellent.
And
So when does that normally occur?
Around 1.5 to 2 years, 1.5 years, one body part, and around 2 years of age.
Well, it's a little, again, I agree with you, it's a little variable, but 15 months, usually many kids can identify one or two. And by 18-20 months, most of the kids can identify all. And some of the geniuses can identify even book pictures by that time. So this is And there is this thing about they may be confusing body parts initially. But they don't confuse body parts with another category. You understand? So in the body parts itself, initially when they are learning, they may confuse nose with eyes and all that kind of thing. But they won't confuse nose with zebra, or nose with horse, or nose with fruit. So that is a very important thing, because it tells you he's learning, and as he grows older, by 18 months, most are champions. They tell you everything, tongue. So most important, one more thing which is always important in development, may not be in this case, is, what is this? Pointing. That's a milestone which is extremely important nowadays, because it's one of the things which does not occur at all, or may occur very, very late in autism. And autism, as you all know, is a huge problem now. And as pediatricians, you have to recognize it's the first sign, besides delayed speech, is lack of pointing. Because pointing is proto-declarative pointing. I want this. It comes automatically. She may not say any word, but so pointing is a non-verbal kind of language, actually. And that's a thing which you must ask for. Because if that is late in the milestones, your ears should immediately, your mind should immediately realize that maybe there's something more to her not speaking. Okay.
At present, she can speak at a time 2 to 3 words.
Perfect. So is that normal, you think?
2 to 3 words should come a little earlier. Right now, she should have been
2.5 years, she should speak 2-3 word sentences, phrases.
No, so did you mean that? Did you mean, she said 2 to 3 words with meaning, or 2-3 word sentence? There's a difference between the two.
Yeah, she just says something like
Speak a little louder.
Roti.
No,
roti.
I roti. I roti means mummy roti. So in other words, there's two words, there's phrases.
She uses two phrases.
Phrases. So that comes earlier, yes. But I mala roti de, there's four words.
No.
That's a sentence.
No, she doesn't speak in sentences.
Fine. So by 2.5, most kids will be speaking lots of sentences. So there's a little delay in her speech. So now tell me, what are the different language developments? What are the different language developments?
Language, there can be receptive and expressive.
Very good. So receptive language, the first thing which you should always ask for, that is? Anybody? Response to name. So when does a child respond to her own name? Around, depends again on, I've seen a lot of variation. But for 5-6 months, if there's no response, again that's very important for autism as well as hearing loss. But hearing loss, because hearing loss, they may have normal babbling. The first she said, she says mama, 8 months. What do you think that was?
No. That is...
Was she meaning mama?
No, she did not mean that was just...
So what is the expressive language before mama? Posterior vocalization.
Cooing.
So you talk about e, o, u. What are those?
Cooing sound.
Vowels. And vowels come initially. That's why vowels are so important in any language. The posterior, they occur 3-4 months. Then at 7 months, what comes? Anterior vocalization. And lip, labial. Ma, ma, pa, pa, da, da. Dada is not really labial, but mama and papa. And that is why every culture has mama, mummy, papa. All these words are similar in different languages. Because these are the first thing that you call your mom out and dad out first. So meaningful monosyllables or meaningful bisyllables like this don't occur at 7-8 months. They occur later. So we say around 1 year. They can occur around that time. When would you consider language to be delayed for sure? When you're really worried. $18 months. Okay? Initially people used to think 2 years, but I think now in the era of autism, please 18 months. No words, no meaningful words. Refer, do hearing test, do everything, but refer. Don't sit and say, bolega, 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 usme pura zindagi nikal jayega. Got it? Okay. So now you come to, at the end of it all, what is your, anything else in the history you want to tell me? You don't want to tell me about, because you are telling me there's what is your end of your developmental history? What is your assessment? Because at the end of the developmental history, you should have, is it global delay or is it specific delay?
The delay is significant in the gross motor milestone.
Okay, so you think it's specific delay. Correct? So now you tell me, in specific delays, so you're saying specific motor delay, you're not saying specific fine motor delay.
No, not.
You're specifying gross motor delay. So specific gross motor delay, what are the groups of diseases which you should think of? Please don't give me the diagnosis in this case because I'm sure you know it. Just the groups of diseases.
Those which involve the proximal muscle.
So neuromuscular disorders. Neuromuscular disorders. Correct? Second group. Okay. Nutritional diseases, cardiac diseases, so any systemic diseases which tend to affect the motor more than the social and language. Correct. So one is that, second is that, third is which other kids with motor delay only? Cerebral palsy, absolutely correct. So tell me somebody, what is the definition of cerebral palsy?
There is a question. What is the difference? What is a monosyllable and what is a bisyllable?
Mama.
So ma was mono and mama was bisyllable.
The cerebral palsy is a non-progressive disorder of
So
movement,
non-progressive disorder of
movement and posture.
movement and posture. So it's perfectly okay. A cerebral palsy could be coming as a specific motor delay. Which one? Which are the types of CP which come with specific motor delay and nothing much in language, nothing much in social, nothing much in
Diplegic spastics.
diplegics and
Hemiplegic.
hemiplegics? Correct. Quadriplegics, very unusual. Which quadriplegics are socially very good but languagely poor? Which are they? That's all of you know. Come on, Dhara. Which quadriplegic CPs have fairly intact social and receptive language? They may not be able to speak because of their dystonia or because of their spasticity. Correct. So basal ganglia lesions which cause a problem in their motor. And what are those lesions? Which is the condition which cause? One is a connectress and the other one is much more common. HIE, central HIE. So there are two types of HIE, I'm sure all of you know that. Central is when the bulk of the illness is in the basal ganglia, a little bit in the cortex. And then there is a peripheral HIE, which is where the lesions are mainly in the, also in the basal ganglia, but also in the cortex and white matter. So this cortex, when the cortex is fired, social language gets fired. But if your basal ganglia alone, I mean, I have patients who can communicate, who have connectors, who can communicate, who are actually intelligent. I won't repeat the story. But that is really true. I mean, if you have, be very careful talking in front of them, because they can understand a lot more than what you think. Okay? What? Finished? So at the end of it, what is your working diagnosis? You said there's a specific motor delay.
Two 2.5-year-old.
No. So what sir is asking is, he discussed these 3-4 groups that are possible with a specific motor delay. So now tell him which of these groups do you think this child could be?
So the mother also gave a history that there was a significant loss in the weight of the child.
Okay. So you think it's nutritional?
It.
Could you please speak up?
No.
Please.
Just go a little closer to the mic.
According to
sorry.
Sir, according to the history, there is no. In the dietary history, there is a thing suggestive of nutritional lack of nutrition.
So you think a caloric intake is good?
And
a caloric intake is good, you say?
Caloric intake is adequate. Still, the child is not is losing weight. So it can.
So what are the conditions where you You have failure to thrive, but you are not gaining weight. I mean, you are eating well. That's what you're saying, right? Or at least
That's the mother's perception.
the mother's perception. Yeah, what do you think?
Yes, sir.
Come on, conditions where you're eating well but still not growing or losing weight.
Protein losing enteropathy. Protein losing enteropathy.
Protein, so any malabsorption. No? It could be gluten also. No? It doesn't have to be protein losing. So lots of, I'm assuming I'm here for neurology, so I hope it's not a, what's it?
Hyperthyroidism.
Correct. So lots of systemic diseases like malabsorption. Now let's come to the neurological disease, because I'm very weak in that area, so don't want to go into that. I mean, do developmentally delayed infants lose weight or don't put on weight? Lose weight is he losing weight? That means you have a documented weight, or you're just saying that the mother thinks he's not eating, and he's eating but he's not gaining weight.
No, the mother gives history that he had good full cheeks, and the baby was initially chubby, but has now become very.
One of the things, of course, you must think about is in this era is, whether there's some HIV or anything of that sort. One of the things you should mention, because he's got some infections. So have you ruled out all those things? I mean, not from the examination, Well, so one of all the systemic diseases, including HIV, hyperthyroidism, celiac disease, other things. What about neurological diseases? Do developmentally delayed infants gain weight normally now? Is that usual? Or so which patients don't gain weight? Typically. So, cerebral palsy, absolutely correct. Why don't they put on weight?
Please speak into the mic. We are requesting you so many times. Please speak into the mic.
Disuse atrophy nahi hai. They are not getting adequate nutrition most of the times because of
feeding difficulty,
swallowing difficulty, dysphagia, recurrent infections in the lungs. So all those contribute to poor weight gain in cerebral palsy. Usually doesn't occur in hemiplegics or in diplegics, because everything else seems to be pretty good. She's speaking, so it's a little odd. Any other conditions where you can have delay, more in motor, failure to thrive? Neuromuscular disorders? Yeah, so some of them have problems in swallowing, dysphagia, but she's saying, so have you asked about the history? How do you ask about the history of dysphagia?
So there is no history of difficulty in swallowing.
How do you know? What is the question you asked? I want to know the question you asked.
There is a regurgitation or...
No, regurgitation is not there.
Choking
during feeds. That's one. And second?
Liquid, the child...
Okay, liquids and solids and all that. It's very difficult to tell you in a baby that he's got neurological dysphagia because liquid issues and all. They're very, very difficult. Believe me. So the second question I ask, this is something I've realized over the time, is, does the baby enjoy feeding? Because babies enjoy feeding when they can swallow well. But if they're choking or they're having coughing and this and that, usually there is an issue of enjoying it. Very often they will say, कि force करना पड़ता है. So what is the situation over here?
No sir, nothing like that is involved. There was, during only birth, there was this history of weak cry, and the mother says that even today the child...
so now you're giving me a new history that the cry is not loud.
The voice is not loud.
Okay, so what do you think what does that mean usually? You think it means vocal cord problems, or it means more likely
laryngeal muscle weakness?
Respiratory muscle weakness, correct? Because you need a good respiratory system to cry loudly. Or you are breathless because of some other reason. You have some cardiac disease or whatever, or something of that sort. But even those kids cry quite loudly. It's mainly respiratory muscle weakness. Sometimes could be vocal cord, but difficult for me to imagine somebody who's speaking. Even now when she speaks, you can't hear her, is it?
No, we can hear her. She just that she cannot loudly call out to the mother.
Okay. So it could be vocal cord or it could be respiratory muscle. Fine. Anything else which can cause mitochondrial disease? You require energy to grow. You require energy to build your muscle mass, to get strength. So many children with Lage disease, for example, have problems in gaining weight as well as delays which are much more in motor. So that's something else. But they don't have usually this vocal cord thing which he's talking about, the respiratory muscle. Okay. Do you want to now show us the case and show us the findings?
So 1 minute, sir. I think Rajesh, that nutritional fellows never have a delayed development unless it is a symmetrical IOGR who has a microcephaly. So there could be a little delay in motor milestone,
right.
but never anything else.
This
and
is
they
too
never
severe.
present with delayed development. They present with stunted or wasting. So I don't think anybody who has a delayed development straight off we get in, unless, as we discussed, only the motor delay, and that's too not a severe motor delay, proportionately. Again, there the earlier motor milestones are not delayed, because usually the nutrition starts faltering
Later, correct.
And sir, they won't get stuck at around 9 months like in this case. So
No, over here he is not even putting his feet down.
yeah, you have to move. Correct.
That is a very odd thing in nutrition.
So there is a question.
No,
Dr. Udani sir, there is a question. Is there something known as a simple genetic delay in speech alone? And
Yes,
when
yes.
do we think of that?
Well, I don't think I would call it that. Maybe he's found that term somewhere. But familial factors play a large in both motor as well as in speech. But at the same time, let me tell you that in autistic children, studies from many years have shown that 20-30% of their first degree relatives have delayed speech. So when you see a child with a delayed speech, yes, his father also spoke late, but this fellow may be autistic. So don't just say, chalo, wo baad mein bolega. Similarly, children who are learning disabled, who are destined to be learning disabled, like dyslexia and all that, they may have delayed speech, delayed verbal acquisition of speech. For motor, yes, very well known. The children sometimes walk late like their parents did, etc., etc.
But that's not an excuse to not investigate. That's the point.
It's a diagnosis of exclusion and maybe almost a retrospective diagnosis.
Yeah, not retrospective, but at the same time, you must be very aware that these things can happen even in patients. So you must not just wait on it. You must think of it, roll it out even clinically. You may not want any investigations. You may not want any investigation, but clinically at least you should, and at least a hearing test, nothing else.
Rajesh, can I say that if a child has normal mental and other developmental milestones, and if his hearing is normal and autism is ruled out, this particular child has only expressive language disorder.
Correct.
And
So what we call that specific nowadays specific language impairment.
And emotionally deprived children will also fall in this category, and they will speak late despite everything being normal.
Absolutely. Because language is really a matter of stimulation. It's earlier in, this has been shown time and again in highly educated parents. The kids speak earlier than, that's one of the reasons why this inequality exists even in equal countries, because meritocracy is not just about merit, it's also about where you were born, accident of birth. And that's one of the reasons why you have to help all these, because these, a kid living in a slum, mother working in this thing, has no time to stimulate. Okay, he will be normal. But he won't be as good as somebody who's in a, mother is sitting with him and reading books to him at the age of 2. It's going to be a big difference. It all depends on stimulation.
Employed mothers and kids are having mothers full time. So kids having full time mother at home and kids having part time mother who is employed outside, they will be different at 2 years.
No, I'm not saying that. You're putting words in my mouth. I'm just saying that in the first 2 years of life, language development depends a lot on stimulation, interaction, and all that. We have seen, and this is something my own observation, that children who are autistic very often are from upper class families, middle class families, not so much from the lower class families. And the reason is very often television is on, mother is working, this is all going on. Now, I don't know whether this is really one-to-one or it's just observation which might have nothing to do with requires case control studies and stuff like that. But there are clearly, and why the American Academy of Pediatrics now says no TV till the age of 2. Why is that? Because social and language interaction is absolutely critical in the first 2 years. I'm not saying people should stop working. Don't.
So in feeding history, the pattern of feeding is also important, sir, because poor sucking that indicates congenital myotonia. Then swallowing problem, the bulbar muscles, the spinal muscular atrophy, like that is also the pattern of feeding, sucking, and how.
So how do you ask all that?
How the child sucking, breastfeeding.
No, fine. He's saying he's feeding, he's sucking fine. She's not having any choking, nothing. So obviously the feeding is okay. Correct?
Yes, sir.
Do you want to bring him over here? Or आप एक काम करेंगे?
We can take a chair and sit here.
Sure. This is one of the problems of this. अब साथ में बैठो लेके बैठो okay no you show me the signs. I'm not going to examine him, boss. जल्दी करो, we will go to the second case also.
Sir, in our CNS exam.
Straight CNS?
General examination of child. Sir, in general examination of child is conscious and alert, interested in the surroundings, sitting comfortably in mother's lap.
Comfortably, is it? Okay, he's sitting comfortably. Depends on what degree of comfort.
Yes. She is she looks tachypnic.
You think it's tachypnea or more than that? I mean, I'm not a pediatrician anymore, but it looks to me like many of his accessory muscles are working. There's suprasternal retraction also, no? Hi, baby. See all this retraction, suprasternal.
Does any of the exam going people want to come and help in the examination?
That's fine, yeah. Come. No, I would rather, then shall we do one thing? Because she's getting upset when you remove the thing. So why don't you examine the CNS? CNS, PNS, whatever.
Sir, on general examination, child On general examination, child is not comfortable. Child is tachypneic. So not a well nourished child. Moderately built. The head to toe examination. CNS higher function. Child is conscious. Interested in surrounding.
So he's interested in surroundings.
He's looking around the people.
Okay. So he's looking around at us. He's making eye contact. Hey, you're smiling also? Nate, check karo na yaar. Hi baby. What's your name? Nee? He's anxious of me. He's looking at me but he's anxious, doesn't want to hold my hand. Okay?
So,
then go on.
Child is conscious.
Okay. Okay. What did you see? Ge. What do you see now? What do you see now?
There is a
so lot of difficulty in
lifting up the upper arm. So there is there may be possibility of weakness of the proximal muscle.
What else do you see now? Look at his eye movements, his upward gaze, his lateral gaze, everything is normal. Come and smile for me. Come on. Okay, take it. Now you play with it. You also see that his fine motor functions, his hand functions are pretty good.
Yes.
Correct?
She is holding the string of the leg properly, so the fine motor looks normal, sir.
Okay. What else you see over here?
Sir, there is a wasting of the muscle of the lower extremity.
She said Diya. He gave me. See, he speaks in words. I'm not sure what phrases. Okay, what are you saying?
There is no other neurocutaneous marker seen on the body.
How can you say that unless you strip the KDR? Yes. So don't just say because what is a neurocutaneous marker? You think it's a neurocutaneous syndrome, for God's sake?
No, yes, it's part of general examination.
No, I understand that. But your examination, when you're talking in an exam, it should be more directed so that, you're sort of honing in on what? What are you honing in on?
Now this neuromuscular.
Neuromuscular disease, huh? You've shown some tachypnea, you've shown some dysphonia, you can hardly speak, you've shown some proximal muscle weakness, so that it looks like you're going in that direction. So if you're going in that direction, then what should you look for?
Lower limb, the muscle wasting is there, and
which could be a nutrition also, no?
Yes, and she is moving the extremity properly. There is no possibility of movement is also there.
Now she's smiling. You saw the smile? So facial muscles are also doing well.
Then come to cranial nerve examination.
No, just don't do. Just inspection and you just say whatever comes first. Doesn't matter. Cranial nerve can come, cranial muscle can come after hand muscle. Doesn't matter. The first thing is get comfortable with the baby. Don't touch him or touch him very little and touch him, like I am touching him, so he's friendly with me already. But don't take out things and go according to mental status, cranial nerves, motor, sensory, or rubbish. Infancy, you do what you can. First, inspection. Minimal palpation, no percussion and no auscultation. A very little auscultation occasionally. That is so what you can see is, what would you look for specifically? I wish you had not tied up his hand here.
There is no gross any hypotonia or hypertonic any contracture or spasticity of the limb.
What do you see over here? Can you focus on this? Can you focus?
Wrist widening is there, sir.
Okay, wrist widening is there. Okay, you tell me. What is that called? Can you see the tremors?
Yeah.
Everybody can see it? It's very minimal. What are they called? Mini myoclonia. So they look like little erratic myoclonus in the hand. And that usually means, in this context, it can mean many things. So you can see mini myoclonus in many conditions. Now he doesn't have severe, unfortunately, it's very minimal. So it's difficult to demonstrate, but all of you should, it is a DNB student should come and look at this to make sure what it is. It occurs more in the hands, but what does it mean? So conditions where you get erratic myoclonus or myoclonic-like movements in the hands. Anybody? So neurogenic diseases. See, she's read about SMA because this kid has got SMA. SMA is coming out at everything. You can get it in peripheral nerve disease. Of course, the most common is spinal muscular atrophy. So, anterior horn cell diseases, peripheral nerve diseases. You can get this. They're called tremors. They're called mini polymyoclonus because sometimes they are erratic and they occur. Each finger occurs differently. Sometimes they're a little bit of tremors. So they can be called that, but they basically means denervating diseases. So the muscle is not usually in there. When you have polymini myoclonus, muscle disease is usually not there. Usually. And then what else can it be? Brain diseases. Which type of diseases? Anybody? No, grey matter diseases. Diseases which affect grey matter. Because these are small little cortical myoclonic jerks. So bad diseases. Grey matter degenerations like neuronal spheroid lipofuscinosis and stuff like that. So obviously that's not the case over here. So this is obviously something which is occurring in a baby because of a denervating disorder. Most likely, as somebody said, spinal muscular atrophy. But this is not the only thing I would hang my hat on because it's not as prominent, and unfortunately we can see only one hand which he's using to play. Okay. Anything else you look for in neuromuscular disease? You agree? What do you think of his voice?
Nasal twang is there.
Would you say it's difficult to comment because she's tachypneic? He or she? She's tachypneic and having problems in breathing right now. I would just leave it at that. So I cannot confirm whether she's got dysphonia or maybe slight nasal twang is there, but nothing really because she's sick respiratory wise.
She's having a grunting is also there intermittently.
Correct. So she's got a respiratory problem for sure. Grunting. She's tachypneic. She's got accessory muscles of respiration. She's got a little nasal twang which can occur also if your nose is blocked and stuff like that. So I think generally I would not comment too much on her. What is interesting is I don't hear something.
Considering that...
Are you hearing any sound? Otherwise नहीं रहता. Very important to listen for sounds all the time. If you are not swallowing properly, these kids, they have the same complaint. Cough jata hi nahi hai. And they keep going to pediatricians who keep giving them antibiotics. But the problem is they're not swallowing their own spit. And therefore that's remaining over here.
Due to some secretion.
Right now, of course, her mother only is telling you that abhi usko bimari hai. Normally रहता नहीं है ना ऐसा. ठीक है.
Considering that the baby is playful, can we say that this low voice and all is due to neurological and not due to respiratory insufficiency? I mean, respiratory insufficiency.
When I have a bad cold, I am also very playful, but I can't speak. So I would be little careful about interpreting that, especially because my diagnosis of SMA will go out of the window. Will go out of the window if I start talking about cranial muscles, cranial nerves. So in your examination you also have to know where you are leading the examiner. If you give all your findings pristine, sometimes you can't explain certain findings, you will land up in a soup sometimes. But over here it looks like a neuromuscular disorder with that proximal. So when you come to neuromuscular, what are you focusing on? 2-3 things. Mainly proximal muscle. This is definite. खड़े करेंगे एक बार, ट्राई तो करो. छोड़ेंगे तो सीधे बैठ जाएगी. So she can't even support her weight on her legs. So there's clearly weakness in the anti-gravity muscles. Kamal problem. So anti-gravity movements, very important. So you're talking about what diseases? Neurogenic, myogenic and neuromuscular junction. You think this is neuromuscular junction?
Sir, less likely. It looks like a proximal myopathy. So
No. Less likely. Why?
Sir, actually, she is having the weakness of proximal muscle. So
you can get weakness of proximal muscles in neuromuscular disease. Of course, you can get. Loudly.
In neuromuscular junction, the weakness of the facial muscle started, and
not facial, but
eye muscles,
ptosis, ophthalmoplegia. Of course, you have facial muscle weakness also, but it's bilateral facial. So you won't be able to tell by inspection unless you make a whole, जोर से ऐसा करो, ऊपर करो, then you can make out. Otherwise, very difficult to tell facial muscle if it is bilateral facial. But you can tell very easily ptosis, which is definitely not there over here. Okay, they can have bulbar muscles, which is possible because of this story and all this. And they can have limb weakness. So neuromuscular is most likely not there. Number 2 is there is no fluctuation. She's never been able to stand up. So it's very unlikely. So forget neuromuscular, very bad. Neurogenic or myogenic, how do you tell the difference? One is this mini myoclonus. It's there but it's not gross. Proximal muscle weakness occurs in both. What are the things which point towards a myogenic? Cranial muscles, 1. So very often cranial muscles are involved in myogenic, but not always, but many times. SMA almost never involved. Peripheral neuropathy almost never involved. Over here the cranial muscles are essentially normal. We're not sure about the swallowing muscles, but second, both of them don't have any brain problems. We agree the brain is normal, right? She looks socially, language, everything is fine. So
there is no gross developmental delay.
So in muscle disease versus neurogenic disease, the absence of a brain problem doesn't help you to differentiate. But suppose there was a little brain issue, what would you go in more in favor of?
Neurogenic.
Myogenic. That's why they are called encephalo. The congenital. This is mainly a congenital myopathy. We are not talking about muscular dystrophy coming later, because this baby has been slow from early life. So it's a congenital muscle disease. The congenital muscle disease very often have mental changes as well. Okay? They may be slow. There are what are called, there are many disorders. I don't want to name any of them, but dystrophic glycanopathies. All these things can have slow development in this thing as well, the mental functions. But SMA typically is very bright. Very bright. Even Duchenne's can be a little slow up there. But SMA and all these neurogenic disease doesn't affect the brain at all. Third, when did the problem occur? आपको कभी मालूम पड़ा कि problem है?
8वें-9वें महीने में.
8वें-9वें महीने में. Many diseases which are muscle present at birth, early life. Of course, they can present later. These are all not absolutes. Please don't catch me and say, no, it can't present later. They can present in adult life also. But generally, SMA does not present at birth. Okay? Last thing. Hold this. Hey baby. So knee there is no contracture. Ankle there is no contracture. Knee there is no contracture. Ankle there is no contracture. So contractures are earlier, let's not say earlier in muscle disease. And occur very late in SMA. Now what else do you want to show me? What are the important things which you haven't mentioned in your examination? Reflexes. So reflexes, tell me about reflexes in neuromuscular junction, muscle disease, and general. I'm not talking in this particular case. What are the reflexes like?
So in neurogenic...
no, in this case.
Here the reflexes are absent.
So reflexes
Speak louder, please.
So reflexes are absent. Okay? This is the worst hammer you should have. You have the round one. Okay, go on. You go on. Tell me about neuromuscular junction.
In muscle diseases, initially reflex might be present, but later as the atrophy or something.
Now let's talk about this case. This is congenital myopathy versus. Or let's talk about early onset myopathic disease with early onset SMA. So jerks are always more earlier absent in which condition?
SMA.
So neurogenic. No, very early also peripheral nerve, but neurogenic for sure. The early absent. Even before the muscle is weak, the reflex may have gone. Okay? Because the reflex, for example, neuropathies are also, if it's a sensory motor neuropathy, the reflex depends on not on the motor but also on the sensory. So reflexes go early in all neurogenic disease as a rule. In muscle disease, when does it go? Let's, for example, take Duchenne muscular dystrophy. What is the usual thing in Duchenne muscular dystrophy?
As the disuse...
Don't need disuse, please. The muscle is weak. It's not disuse.
Atrophy of the muscle.
No. Tell me what happens in DMD. You tell me.
In DNB, there is a muscle weakness will be there. That will.
Which is the reflex? What are the reflexes in DMD? Bolo na yaar.
Ankle.
And
ankle jerk last to disappear in DMD.
And knee jerk.
It will disappear earlier, knee jerk. And
so what does it mean? Why does it happen that way?
Achilles tendon.
Tendon को क्या हुआ?
Proximal muscle.
So muscle loses a reflex depending on its strength. Now, which is the muscle which is the strongest in the lower limb in Duchenne's? Gastrosoleus. Which is the ankle jerk? Which is the muscle it uses? The gastrosoleus. Therefore, it remains. Why do you get contractures? The Achilles tendon contractures in Duchenne's? Because dorsiflexion is weak, plantar flexion is strong, so you remain like this. That's why you toe walk in Duchenne's. You toe walk in Duchenne's. You have a preserved ankle jerk till very late. You have a strong muscle, which is the muscle that become weak in Duchenne's.
Proximal muscle.
No, not at all. Remember, dorsiflexia is a proximal muscle? No. So in all muscle diseases, remember the pattern of weakness involves patterns of muscle weakness. In SMA it is usually proximal distal. So this kid, proximal is weaker than distal. But in Duchenne's, for example, I'm giving you Duchenne, but there are many muscular dystrophies, there are many muscle diseases. And this is really applicable to muscular dystrophies, where you get a progressive degeneration and a regeneration, etc., etc., like DMD, Becker's, dyspholinopathy, sarcoglycanopathies, etc. So certain muscles groups are stronger than others. For example, in Duchenne's, dorsiflexors in the ankle always weaker than gastrosoleus. Hamstrings always stronger than quadriceps. That's why the knee jerk goes first, because quadriceps is weaker. It doesn't go very late, so you lose this reflex a little earlier than the ankle jerk. What about hip flexors and hip extensors? Both are weak, but hip extensors are usually weaker than hip flexors. So there are patterns. Adductors are very weak compared to the abductors of the hip. These are patterns which tell you this is probably a muscle disease. In SMA and all that, more proximal. In peripheral nerve, more distal. But not specific muscles. You understand what I'm saying? And in neuromuscular junction, what happens to the reflexes? Usually normal, preserved. Okay. How would you investigate this case? Anything else you should see clinically in these kind of cases? How much time do we have? Can we go on to?
There's another case. But what about fibrillation? Do you look for fibrillation?
Let's talk about the types of SMA. And what are the problems of looking for fibrillation or tongue fibrillation, which Dr. Amdekar was talking about. When you look at the tongue, the baby cannot be crying. The baby has to have the mouth open. वो कभी होता है क्या? मुंह बंद होगा तो दिखता नहीं है, मुंह खुला होगा तो जनरली रोता है. So it becomes a problem to know fibrillation versus just tongue movements because of... Yeah, that is the polymini myoclonus. That is the polymini myoclonus. I'm talking the tongue. Because tongue is what most people are, fasciculation. Because you don't get limb fasciculations as commonly as in motor neuron disease. You do get this polymini myoclonus, which is probably, small muscles fasciculating away. But basically, in motor neuron disease, ALS and all in adults, you get these, fasciculations of big muscles. That doesn't happen commonly in SMA. Second thing is, what are the types of SMA? Anybody else can answer now?
3 types.
4 no, types. Somebody else.
There are...
Same. Achha, why don't you get up? Anybody else from behind? You finished your DNB? खत्म हो गया था, हाँ? हाँ तो दे दो उसको दे दो. What is SMA 1? What is SMA 2? What is SMA 3? There's an SMA 4 also, but as far as we are concerned, SMA 1, 2, 3. How do you clinically differentiate SMA 1 from SMA 2? Age of onset. SMA 1 can present at 0 to 3 months, 1 to 3 months.
Early infantile.
1 to 3 months. And SMA 2 can present from 3 months to 6 months. So, suppose it comes at 3 months, you're not sure? So, SMA 1 never sits. And respiratory muscle weakness is early. SMA 2, walking is the issue. Sitting is there. SMA 3, they walk but they can't run. And SMA 4, as far as we are concerned, occurs in adult life, is a different disease altogether. It is not from the same genetics. But all these 3 are all the same genetics. And what are the genetics? Tell us.
Survival motor neuron.
Yeah.
Actually, survivin gene is there. That is a
Survival motor neuron gene.
He is correct. Survival motor neuron gene, SMN gene, correct. What happens in that?
Actually, in the fetus there is excessive neuroblast is generated, and
No, don't talk about the pathophysiology. That's too confusing for me also.
Yes,
I'm just saying there are deletions in axon 7 and axon 8 in the survival motor neuron gene, which is on chromosome 5. And 95% of SMAs will show this. So it is a very easy case to diagnose. Is it positive or negative? It's positive. So there's no doubt about the diagnosis once this comes positive in a clinically fitting patient. Okay? So this is the genetics of SMA which you should know. And therefore, how would you investigate this patient? Somebody can tell me? Madam, how would you investigate this patient? She's asking next door. What about CPK?
CPK.
You must do a CPK. Clinically even I'm not sure sometimes, and sometimes we get surprised. We think it's SMA and turns out to be some myopathy. So CPK is a must. And the CPK in this case turned out to be 250 or 300? How much is it? Not done only. Okay, fine. They are sure of the diagnosis. Suppose the CPK is 250, 300. SMA excluded? Tell us, Pulak.
It can be mildly increased.
Yes, usually mildly increased in SMA1, SMA2. Why it is mildly increased, I am not very sure, but there is definitely mildly increased. So mild increase in CPK does not make any difference. It never comes in thousands. So it comes above 1,000, then it's a muscular dystrophy. Otherwise, and remember, in CPK it can be normal in structural myopathies as well. So you may have a central core disease, normal CPK. Somebody said EMG. Would you do EMG?
Yes. Sir, EMG and NCV nerve conduction study we can do 2 degrees.
No, you can do. Will you do?
EMG is sir not.
She hasn't done the CPK. Have you done the EMG? No, but did somebody do the EMG? EMG has been done. CPK also has been done. Not done. Okay, EMG was done. So EMG you do. What does EMG tell us?
If there is a muscle denervation or is there, then it will be the response will be decreased.
So I will not go into EMG now, but basically it is to differentiate between myogenic and neurogenic. And it helps us to find out if there is a significant slowing of nerve conduction like a peripheral neuropathy or not. It's a very painful, very uncomfortable and horrible test to do, which I do all the time. But if your patient can afford it and if you can clinically think this is SMA, go straight for the gene test. That's the point I'm trying to make. That nowadays, this EMG, NCV, people do EMG and form DMD. You do a CPK in a child who is compatible with Duchenne muscular dystrophy, comes at 5,000 CPK. You don't do EMG nerve conduction, you go straight for genetics. So you do EMG nerve conduction only when it's required. Just don't do blanket कि जब भी neuromuscular आए तो 3 तो करने का है CPK, EMG और muscle biopsy. Never do muscle biopsy in DMD. Never. Except in anybody? When you are not sure.
Similar presentation in girl, child, or gene report.
If the genetic report is negative, and that includes how many axons? 79, not the usual 30. Normally the genetics is done is 30 axons. You should do all 79 if you are absolutely sure. And then if that is negative, or if you have a problem of differentiating a late DMD from an early Becker, then you might do a dystrophin staining to see. If there is no staining, it's DMD. If there is staining, it is significant 20-30% staining is Becker's. So those are important things. Otherwise, muscle biopsy is out of the... Nobody does muscle biopsy nowadays. And especially the way we do muscle biopsy. We do routine H&E. Completely useless. If you cannot do immunostaining, for which you have to go to 2-3 centers and 3-4 centers in the whole country. There's one center in Bombay, there's one center in Nimans, one center in Ames, one center in a few other cities like, big institutions. If you can't do that, forget about doing it. And it's done in the GP level, actually, muscle biopsies. Anyway, anything else you want to discuss? How will you manage this child? Ab jayenge ji? This is the important thing which she has made me realize. What are the long-term complications of this condition? Scoliosis. This is already developing over here. Last question, somebody. How would you counsel this mother? Anybody want to take it up? What do you tell her? She is waiting for me. I have to also go and tell her. Nobody?
Would tell her that your child has a...
That's what I was told. Is it true or not? So please counsel.
Hindi sir.
बोलिए क्या मेरा बच्चा चलेगा?
आपके बच्चे को I don't know what do we call for him. नस में तकलीफ है, उसके वजह से वो जैसे बाकी दूसरे बच्चे उठ के बैठ के चल पा रहे वैसा नहीं कर पा रहा है आपका बच्चा. बाकी बच्चों से स्लो है.
So very good. आपने बताया, she has told us that what the disease is. And when you use words, you must use the language which she understands. So nas is okay, snayu is okay, muscle की बीमारी है, स्नायु की बीमारी है. You must say that you are absolutely right. You must explain. ये तो बिल्कुल ठीक है. दिमाग में कोई प्रॉब्लम नहीं है. Because the first thing she told me is यहाँ प्रॉब्लम है. She told me the hips, there is some problem with the bones. हड्डी में प्रॉब्लम नहीं है. ये स्नायु में प्रॉब्लम है, नस की बीमारी है. तो इसकी वजह से उसका स्नायु ताकतवर नहीं है और इससे चलने बैठने में सब स्लो है वगैरह वगैरह. चलेगा? बताइए ना क्या कर रहे हैं.
अभी फिलहाल खड़ा नहीं हो पा रहा है. थोड़ा एक्सरसाइज चालू करके देखते हैं बैठ पाएगा क्या पहले करके.
Excellent. Never tell the truth on the first visit. Unfortunately, I tell the truth on the first visit because they don't come to me again. But frankly speaking, this is a diagnosis to be told over months. You know, keep saying, पता नहीं है, चल भी सकता है, चल भी नहीं सकता है, लेकिन पता नहीं है, दवाई देंगे, एक्सरसाइज करेंगे, इम्यूनाइजेशन देंगे कि दूसरी बार इन्फेक्शन ना हो, थोड़ा रेस्पिरेटरी फिजियोथेरेपी करेंगे, छाती का which all of you should do in this case. उसका एक्सरे निकालना पड़ेगा देखने के लिए कि उसका जो हड्डी पीछे का है वो टेढ़ा हो गया है कि नहीं. वो होगा तो एक जैकेट पहनाना पड़ेगा शायद, अभी नहीं, छाती ठीक हो जाएगी बाद में. लेकिन you can't treat it, but you can manage it. And management doesn't mean just कि चलो ट्रीटमेंट दे दिया ठीक हो गया, like एंटीबायोटिक देते रहते सबको. You have to manage the family. What else? और क्या बोलेंगे आप? What else besides all this will be part of management?
Go for second child.
Huh?
Go for second child.
अच्छा, you're telling her to go for second child. इसको
Later on.
euthanize this one and go for second child. How many kids does she have?
She has 2.
So why go for third child then?
First child, then we can promote.
एक अच्छा लड़का है ना, और लड़का लड़की डजंट मैटर, परफेक्ट. आपको और बच्चे चाहिए तो क्या करना चाहिए? आप क्या एडवाइस देंगे?
Prenatal counseling. So.
अरे मेरे को काउंसल करना.
Genetic study before you plan for the baby.
नहीं जेनेटिक किया ना उसका, ऐसे में जीन इज पॉजिटिव ना, डिलीशन इन द जीन इज पॉजिटिव ना. क्या करना चाहिए मुझे? अब बताइए ना, कहाँ जाऊं मैं, क्या करूं? एनीबडी? कम ऑन, स्फूर्ति, टेल देम. टेक अ माइक, टेक अ माइक.
Even when you're planning for your next child, like in between 10 to 12 weeks of pregnancy, you'll have to go for a CVS and get the same genetic test done, so to rule out this disease, because there is a high possibility that your second child may also be affected. No.
So you must say the possibility is 25%, but many of them think कि 4 बच्चे की एक को होगा. ऐसा नहीं है. धोनी 4 बार साला टॉस करते हैं, चारों बार टेल्स भी आ सकता है, चारों बार हेड्स भी आ सकता है. So every pregnancy is 25%, and that has to be told. Suppose this patient was a DMD, how would you advise? What are the questions you would ask the parents or the mother? Of course, the family history is negative. DMD, Duchenne muscular dystrophy. Anybody? Same thing? Nobody can tell you.
Is mother carrier, we can see.
Okay. She is a carrier. So what do you do?
Same we can see.
How do you establish carrier?
We can see CPK.
CPK is given up now. You cannot do carriership. The older you are, the less likely your CPK is going to be high. And CPK is it's a screening test for carriership. You cannot do. Genetically you can do a carrier. So the same things, I don't know the details, but genetically you can do the carrier status of the mother. But important than that, the first question you always ask this kind of, कितने बच्चे हैं? और बच्चे करने हैं कि नहीं? So in this kind would be okay for a autosomal recessive. This is a X-linked disorder. So कितने बहना है आपके पास? बहन की उम्र क्या है? कितने बच्चे होने वाले हैं? I remember many years ago, I had done this exercise for a patient with DMD. She had a sister. We checked her, she was a carrier. We checked the sister. The sister was also delivered a baby a few years later. We checked the baby. Baby was fine. We forgot to ask the grandmother's side, their mouses, and that line. And years later, somebody came to me and said, that patient, this guy's got the same thing. So you have to draw a family tree on the maternal side. You have to identify the potential mothers who could be carriers and who are in that age of producing babies. And it is your absolute duty to check all of them, or at least encourage the parents and encourage the entire family to go for genetic studies. Because if you have one Duchenne's, of course, if you have a second sib who turns out to be Duchenne's, you should be executed. But even if your faraway relative gets it, that also is terrible. So the only thing you can do in genetic diseases is prevent. And prevention means genetic counselor. Over here we don't have genetic counselors who will sit with the patient and all that. You have to be the genetic counselor. So you should know these diseases. Common things like SMA and DMD come to you all the time. I've seen so many patients of DMD. Second bachcha bhi aisa hi aaya. Nobody told. Nobody did anything. So I think that is the one thing you must do. I think we'll stop here. Is there any water? Take it back.
Good evening, everyone. My patient, 2-year-old male child, second by birth order, born of non-consanguineous marriage, Sikh by caste, Muslim by religion, brought by mother with chief complaints of not attaining developmental milestones since 6 months of age. I would like to start with the birth history. Mother was ANC registered and immunized.
Before you do that, remember, chief complaint is chief complaint. So you must give some details. How did she realize it? What made her go to the doctor? Why are you saying she is not attaining? Is she regressing or not? Is she attaining slowly? All these are very important questions in the chief complaint. That is not the birth history here. You're going straight for etiology. So that's how you start. Tell me how they noticed it and what exactly. Was it a gross motor delay? Was it a fine motor? What did they exactly see?
Also, I think, are you trying to say that this child has not attained milestones for the last 6 months?
No, since 6 months of age.
So be clear about that. There is confusion.
2-year-old. Initially, the mother had taken the child to a private doctor there. He told that child is not appropriate for. He had not achieved head holding at the age of 6 months. Then cooing and cooing and was achieved at age of 2 years. And he was not able to recognize mother's social smile was absent.
Boy, right? So what has happened after 6 months? Onset, duration, progress.
After 6 months, the child started achieving milestones, but at a...
What milestone did he achieve? You said at 6 months he was not holding his head.
In gross motor, head holding he achieved at 6 months, followed by that partial turnover was present at 7 months of age. Then sitting without support he achieved at 1 year, and sitting up from supine position at 2 years of age.
Okay, so now you are saying there is a progress of milestones. Okay. Go on. Any other milestones you want to tell us about?
In fine motor, crude grasp he achieved at age of 1 year. And language monosyllable at age of 2 years.
Does he eat biscuits by himself?
No.
Does he hold any glass, any bottle or anything like that?
No.
So what does he have grasp for? What does he pick up?
For toys and all.
So he reaches out for toys. Acha. Then?
Social, he started recognizing mother at the age of 5 months. Social smile was achieved at 5 months. That's it.
What is the important social milestone you should tell us? Is he stranger anxious?
No.
If you don't know, just say I haven't asked. Doesn't
No,
matter.
stranger anxiety is not present.
Stranger anxiety is not present. So he doesn't know a new person at all. Goes to anybody. Does he play
Yes.
with people?
No, he plays like with his mother.
Okay, go on. What about language?
Language monosyllable was achieved at the age of 2 years.
What do you mean monosyllables?
Like he just says mama, ma. That's all he says.
No, but without meaning. Yes or no?
No, only he addresses his mother by that. Otherwise, he doesn't use any word.
So he calls his mother Ma.
Hmm.
So you think it's a meaningful? We're not sure. Does he do any imitation?
No.
So you think if he's not imitating, you say he doesn't know his name also, right?
No.
So he doesn't
But he
know his
responds.
name. No, he doesn't know his name, but he can say Mama or Ma. You think that makes sense?
He responds when called. He responds when called. Like
He responds.
knows,
So he knows his
he
name.
knows his
Sorry,
name.
maybe I missed that. So he knows his name. Is there any imitation? Tata.
No.
Does he play any game like, hide and seek?
Peekaboo, he plays with his mother.
Okay, he does that. Okay. Fair enough. Okay, now you can go back to your...
Birth history. Mother was ANC registered and immunized. However, did not take iron and folic acid supplements. Quickening was present at 4 months. Antenatal USG were done twice. Both were normal.
I'm sorry to be this pain in the neck, but really, how is all this important? Folates and quickening and... It's like, you're going through the motions. You're asking the questions whether the person comes with a respiratory problem at the age of 10 or whether he comes with a neurological problem at the age of 1. The same questions are asked. I just feel that your history should be relevant, should keep the person's attention. Quickening. Suppose the quickening was not there, what do you think this problem would have been? That's what I'm trying to say. I'm not trying to criticize you. I'm just trying to say that your history should be interesting for the examiner. Go on.
There is no history of any exposure to radiation, no history of ingestion of any drug, no history of hypertension or diabetes or hypothyroidism in mother. It was a full-term normal delivery. It was meconium stain. There was a meconium stain amniotic fluid. Baby did not cry immediately after birth. Required undercord suction, bag and tube ventilation, and was put on ventilator for 6 days. He had 3 episodes of focal convulsion. He was extubated on day of life 7 and started on nasogastric feeds, and he was discharged on day of life 10. Following that he was breastfed till now he is on breastfeed.
So what do you think, what would you call that neurologically? What was that?
There is a etiology of birth asphyxia is present. HI grade.
See, it's very, when you say birth asphyxia is present, you need certain criteria which obviously most of the patients do not have. So you need, APGAR scores, and you need a pH, and you need evidence of, liver dysfunction or kidney dysfunction and all that stuff. So you really don't know whether birth asphyxia occurred. All you are saying is, neurologically, meconium aspiration, fine, could occur in birth asphyxia, could occur in many other conditions. Ventilation, maybe it was because of meconium passage. Okay, so she required tube and all that because maybe there was a little glob of meconium and aspiration and all that. So, but what is the neurological significance of your history?
Hypoxic insult to the
No,
brain.
no, 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 no. What is the neurological part of your history which will tell you that it might be hypoxic?
Conversion.
Seizures. So what is that called? That's called a neonatal encephalopathy. So that's the important thing. You say there was a history of neonatal encephalopathy, and depending on which day the encephalopathy is, tells you the etiology of your problem. So tell me, what is the most on day one?
Hypoglycemia.
No, day one is not hypoglycemia. Day one is hypoxic ischemic encephalopathy or birth asphyxia. Day 3.
Hypocalcemia or hypoglycemia.
Hypocalcemia doesn't give rise to an encephalopathy. We are talking about the early onset hypocalcemia is usually part of asphyxia and stuff like that. The late onset doesn't give rise to much of an encephalopathy. The patient is feeding, everything is happening fine. So, hypoglycemia. So day 2, day 3, day 4, those are the times when hypoglycemia pops up. What about day 7? Suppose the patient was doing fine till day 6 and day 7 he becomes ill and stops feeding and he then has a convulsions and etc.
Infection.
Yes, meningitis, very good. Meningitis. Inborn errors can occur earlier also, but that's the time all these things occur. So when you say encephalopathy, it's just a term. It just means feeding issues, it just means altered sensorium, it means seizures and all that kind of stuff. So we do not use the word birth asphyxia because you do not know whether it was birth asphyxia. There is likely to be birth asphyxia. But neonatal encephalopathy is a more broader term.
So developmental history
is done.
Yeah.
You want to bring in? Anything else you have in the history?
Sir, he has a hand preference, like left hand preference since the age of 1 year. There is history of tightness of the body and there is history of constipation. And hearing and vision are apparently normal as a child responds when called, and social smile is present and eye contact is present. He follows objects.
Is there any important negative history which you must tell me?
There is no history of involuntary movements, no history of recurrent LRTI, no history of
involuntary movements means what?
Any repetitive movement.
Now what are you alluding to? What are involuntary movements? You think extrapyramidal. But you said that he becomes tight and he becomes stiff and all that.
That's due to contracture is present. Like
No. That could be because of dystonia. It could be because of spasticity. From your history you can't tell, right? From your examination you have to differentiate the two, but basically from your history you can't tell. What should you always ask in a patient who's got this kind of problem? Negative history of anybody. Which should be important for management. Seizures. Are there any seizures?
No history of seizures.
You think
he
it's
had
important?
Convulsion only in the neonatal period.
Correct. So if you have what kind of seizure do you think that was?
Hypoxic.
No. What is it called? What type of seizure? Is it epilepsy?
No.
What was it?
Due to encephalopathy, hypoxic.
So what do you call that? Acute, provoked or symptomatic seizure. And now does he have any seizures?
No,
is it important to know that?
Yes.
Why?
For any...
Because it depends on how many... If you have a cerebral palsy, up to 50% can have epilepsy. It's a very important history. And sometimes the history may be, you may one time fever convulsions may have occurred, etc. It may not be given that much importance. So that's important. Now, do you want to tell me what you think at the end of your history? History. What do you think is the most likely problem?
He is a 2-year-old male child with static encephalopathy.
Okay.
With which is non-progressive.
Yeah, that's what you mean when you say static.
Hmm.
With
And
anybody else? Is there a third year student over here? Your third year?
second.
Second. Is there third year some exam going come? Or you've already come once? Anybody else? Try and take third year. DNB going patients. DNB going students. You are. Why don't you come? So at the end of a history, what do you think is going on?
Sir, there is an insult in the significant insult in the neonatal period. So it looks like.
No, what does he have first? When she said static encephalopathy, what does static encephalopathy mean?
The insult has already occurred, and
what is the word term? Static is a chronic encephalopathy. But you have to, from the history, you got to tell me which areas are maximally involved. So what are the developmental conditions which can happen or which can be part of a static encephalopathy? You can have cerebral palsy, very good. You could be just mentally challenged. Of course, you don't diagnose that till after 5 years, but global developmental delay without cerebral palsy. Third, autism. Even that's a static encephalopathy. So you got to tell me from her history, what do you think is happening?
It looks like cerebral palsy, sir.
Okay. That's all?
With global developmental delay.
Correct. So he's got probably evidence of issues in social and language as well. Correct. So it's more than just cerebral palsy, which is purely motor. It's much more than that. Anything else?
And there is, she said there is tightening, so there might be dystonia or.
Fine. So that's part of the cerebral palsy.
Yes,
shall we get her? बहन जी यहाँ बैठ जाओ. Hello. You can come from here, brother. You want to see it. You're going to be describing this. We are both on, mute. So you go ahead. Hi. What do you observe?
Sir, a male boy sitting, 2-year-old sitting.
So just give me positive findings.
He's looking at the surroundings.
He's looking at us. He's looking at you also. So he knows
there are people.
Around. He looked at the.
Looking disinterested.
What do you think he showed now? Which he said doesn't happen. She said there was no stranger anxiety. There is stranger anxiety. आप दो उसको. ये हाथ से दो. अच्छा ये ऐसे रखो, ये थोड़ा टर्न करके. नो उसको बच्चे को ऐसा. अच्छा ठीक है. He is very strange and anxious. If I go close to him, he starts screaming. What kind of grasp do you think he had?
A crude palmar grasp.
Yeah, so like a palmar grasp, a whole grasp, no? Primitive grasp. He's very tense, he's looking all around. दूसरे आदमी के पास जाता ही नहीं है ना? जाता है? अभी मैं लूंगा तो आएगा? अच्छा. Okay, what else do you observe? Neurologically.
So there is microcephaly.
Correct. So very good. There is macrocephaly. Eye movements. In a developmental case, what are the important points? One is of course the head size, which you said. Second is, he showed what? Casting.
Yeah.
He took the thing and threw it. So that's like a 1-year-old. No? The hand function is pretty. हाथ में बिस्किट लेते खाता है Eats. पेशाब कर दिया कोई बात नहीं साफ कर देंगे वो भी हंस रहा है You can see the facial movements are very good. So just tell me what you're seeing as you're talking. What do you think is okay in his cranial nerves?
There is no facial asymmetry.
Correct.
Extraocular muscles
are normal.
Yeah.
He's got little
Sir, there is periorbital
puffiness of the lids. Absolutely. उसका ये पहले से ऐसा है कि अभी अभी हुआ है? अच्छा. पहले ऐसा नहीं था. ये थोड़ा सूजा हुआ लगता है ना? और अभी अभी हुआ. पेट भी सूजा हुआ है.
Generalized. There's Anna sir का.
हाँ, there's Anna sir का. Okay.
He's looking pale.
He's looking pale. So now we come to the systemic part. Okay, forget about that then.
The right.
You said he's not using the right hand.
Yeah.
So can you, let's demonstrate that. Don't touch him. आप कुछ दो ना उसको ये हाथ में. ये बाजू रखो, ये बाजू रखो. हाँ. ऐसा बीच में रखो और ये हाथ से दो. ये हाथ से आप दो. नहीं, show so that people can see. ये ले. ले. So you can see fisting. What else do you see? एक थोड़ा निकालो ये कुछ नहीं करते हैं बच्चों रो मत ये ले So what is this?
This dystonia.
Yes. आप लीजिए ना उसको दो ये हाथ से So there is a little bit of twisting movement. What is dystonia? Twisting movements which are either mobile or fixed, but basically around the joint, axis of a joint. So this is a twisting movement which he's got. He's got fisting. And look at the hand over there. ये भी निकालेंगे तो रोएगा तो नहीं ना? तो निकाल दो पूरा. गर्मी है आज. और कुछ नहीं कर रहे अभी चुप बैठ. Oh God. ये भी निकालो. दूसरा पहनेंगे दूसरा. Yeah. He's also happy. He was feeling a little warm. Yele? One thing is, he's crossing the midline. Now crossing the midline at 2 years is okay. But if you cross the midline before 1 year, it's definitely abnormal. If you show something over here, you should use the right hand. If you show something over here, you should use the left hand. You should not cross the midline. Now, of course, he can. So you're still not sure whether the hand is plegic, but you basically have shown there is dystonia, there is fisting. But he's using it. It's not that he can't use it. ये चाहिए? ये ले. Okay, so he's using at least 2 fingers and a thumb.
Yeah.
It's not a perfect pincer, but it's not bad. ये हाथ से लेना. There's a lot of twisting. He's trying to use it, but he maximum can try a primitive grasp. So there's clearly a difference between the two. Why do you think he's pronated? Keeping his hand like this.
Hemiplegic.
What does that mean? Hemiplegic, yes, but why is it like this? Which muscle is more spastic? Pronator or supinator? Pronator is spastic and therefore supinator is weak. Remember, in spasticity there is one group which is spastic and tighter and stronger, and one group, the antagonists, which are weaker and hypotonic. So for example, this is the way you do you can see there's a clasp over here. I can do it all the way, but he doesn't like it. What become? Perfect. You can see there is no spasticity over here at all. To demonstrate, I'm not doing it faking it. The other muscle, which is spastic, upper limb. Biceps. So, let's see the normal side. Perfect. Always do a rapid movement. You can see it, no? See this, how fast it moves? And third muscle?
Lower.
Remember the position of the arm in spastic hemiplegia. Adducted, flexed over here. So that means wrist flexors are spastic, pronators are spastic, biceps are spastic. So that's why your arm is like this. And the exact opposite muscles, supination, wrist extension, triceps, and abductors are weak. Got it? That's how it is. Let's see the lower limbs. कुछ नहीं करते. This is all hyperproteinemia. Do you see anything different? Do you see
The foot is little
lower on the keeper like this.
right side. There is plantar, little plantar flexion then.
Yeah, it's a very soft thing. I'm not sure. यहाँ लेके आओ ना. हाँ, खड़ा करो आपके साथ ही. So not too bad. What you must look for is whether it's plantigrade. Usually when you walk, how do you walk? Toe first, heel first? Heel first. Obviously he's not walking, so you can't tell. But when they're standing, if they're slightly up, that's very much like a spastic gastrocsoleus. Okay. Now do you want to just show me the better? He's resisting. He's resisting on both sides. Hold it. Hey, your name क्या है? वो तो मालूम है. Not much. So really not much. So what do you see over here? You finish the cranial nerves, you finish the muscles, anything else? Reflexes? What are the reflexes like?
Wrist.
Both sides, one side?
Both sides.
Both sides. Okay, let's demonstrate, sure. हो गया. Okay. That's normal, no? This brisk is normal, no? I would be tempted to call it normal. think the reflexes are okay. Anything else you want to show us? बिठाएंगे? एक minute. Does he have a field cut? A visual field cut? His vision is normal? He's turning his head. Can you show me how you demonstrate that? No, you have to have two things. So you got to have two attractive things. Fine, you do all that. Show it now. Once you show it, then people remember. There he looks. You saw that? He was looking at this. Let's try it again. There he looks. So the left field is fine. He's not interested in this. That's the problem. Fine on both sides. So that's a very gross way of finding out. Obviously you will not pick up small defects, but generally at least big defects you can pick up. It will score some brownie points in the exam. That's for sure. So now what do you think is the diagnosis? एक बिठाओ एक बार बिठा दो. When you make a child like this sit, you want to see हो गया ले ले ओके छोड़ो. Long sitting is difficult in a long sitting means your legs are extended and your back is reasonably straight, and that's very difficult with spasticity in the legs. Which particular muscles? Hamstring. So with this you can know the hamstrings are not very tight. Gastrosoleus you also checked, it's not very tight when you make him stand. And you do vertical suspension. So there's no adductor tightness either. So legs are reasonably spared. ठीक है, लेके जाओ.
So in this case.
So now tell us what you think here. Summarize the findings, summarize the history, and tell us.
A 2-year-old.
क्या कुछ भी समझते हैं क्या? टाटा समझते हैं? टाटा समझते हैं? करते हैं? वो मालूम मेरे को नहीं करेगा, लेकिन टाटा करता है. और उसको पूछेंगे पंखा कहाँ है, लाइट कहाँ है. अच्छा, ओके, ठीक है, लेके जाओ.
A 2-year-old male child with global developmental delay with right hemiplegia. Sir, I'm not sure whether it's hemiplegia or monoplegia.
Fine.
With static encephalopathy, secondary to...
This static encephalopathy, the most rubbish word I ever heard. Why don't you say right hemiplegic CP? Anything wrong with that?
Right hemiplegic CP,
affecting the upper limb much more than the lower limb. Correct? Is that important? I mean, if it's lower limb more than upper limb, where is the problem? If it is upper limb more than lower limb, where is the problem? And what is the problem in both cases?
Lower limbs more than the upper limb, it's more of periventricular.
Very good. Yeah. Periventricular motor areas, very good. That's exactly what happens in spastic diplegia. Correct. And in upper limbs more than lower limb? MCA stroke. Most typically it's a stroke in the MCA area where you get more of a fasciobrachial. So face and arm paresis rather than a leg paresis. Leg paresis comes with anterior cerebral artery. So this is very typically of a patient who's had a stroke. May not be on the MRI, you might find something else. But clinically at least it looks more brachial than lower limb. Why is the face not there? You said there was no asymmetry of face. Abhi to bolta hai, same boring stuff he teaches me in hospital. Anybody?
It's not more dense.
No. Anybody? Which hemiplegia doesn't have a facial? Congenital hemiplegia. So very early life hemiplegia. Especially if you are born with it. Usually you may have a little bit even if you achieve it in the newborn period. Later on it's almost always there, though it may be very mild and you may miss it. But the congenital hemiplegic will not have a facial because it is bilaterally innervated, the upper part of the face and the lower part of the face. And then later on that you lose that and therefore it becomes more obvious in later life. So when you're having a patient who has a hemiplegia with no facial, you can say with a reasonable confidence that this is probably very early, congenital. And maybe if you have a facial, you can say it's postnatal. Okay. How would you investigate and how would you treat? And how would you counsel? So first, investigations.
MRI.
Why? You have a history, you have an etiology, why you want to do MRI? You obviously done it. Have you? Not done. Good, very good. So Sion Hospital is very good. Chalo. So what would you do? What would you investigate this particular child for? Primarily.
Any coagulation?
No, for the anasarca. Neurologically, frankly speaking, the only investigation you need to do, and that too I am not so sure in this case, but generally in CP, is what?
Hearing and vision.
Okay, so Bera test, fine. And vision? In this case, what would you do?
Fundus exam.
That's all. You know his vision is fine. He's looking, he took back, everything is fine. That's all the ophthalmologist can tell you. If you want to do a little more, fine. Do a fundal examination. Do not do a VEP. Okay, because VEP has no role in evaluating vision. You can have an absent VEP with preserved perception of light, and you may have a normal VEP with almost completely blind. Because that doesn't help you. So VEP should never be done in these kind of situations. Anything else you would like to do? I usually like to do X-ray hip. Why?
Dislocation of the hip.
Yeah, it's usually more common in spastic diplegics, quadriplegics, etc., not in a hemiplegic. Because in a hemiplegic, the usual muscle in the leg which is involved is gastrosoleus. In a spastic diplegic, it could be gastrosoleus predominantly, it could be hamstring adductors predominantly, or it could be all three. But in a hemiplegic, it is usually gastrosoleus. So very unlikely to have a spastic dislocation of the hip, but it's a good idea to get it done once. Okay. How would you manage? Physiotherapy. What would you tell your physiotherapist? Anybody tell me? Anybody heard of constraint induced movement therapy? Yes, you were nodding your head.
In case of hemiplegia, we make the child, the normal part is actually like you can tie and then do the, for the weak, weak side, we make the child do all the activities so that the affected side improves.
So in other words, what you're doing is, you're doing a very simple thing, you're constraining the normal
We tie the normal
limb.
parts of normal.
Very difficult to do because kids, obviously, they are not going to like that because they can't use their hands. So he keeps trying to get, he starts crying and all that, but still, beginning you do 15 minutes, half an hour, 1 hour, 2 hours, 3 hours. People have gone all the way to even putting a plaster on the normal side to help the other side take over. Now, there is a very big scientific reason for this. Anybody know this? When I want to move something, say I want to move my right hand. The left hand gives, the left brain obviously has to be on go, but the right brain has to be no go. You understand? So, naturally, there's a balance between go and no go on any movement. So whenever I want to do a particular side movement, the opposite side has to be actively inhibited. Which is what happens in a patient of hemiplegic CP, this imbalance is there. So over here, the right side was weak, the left side can't move it. So whenever he tries to do something, the right side of his brain gives the go signal to the right side and a no-go signal to the left side. So inhibits it further. Got it? So what you have to do is inhibit the normal side. And there are various ways people have done this. One is of course the CIMT, Constraint Induced Movement Therapy, and believe me it works. In randomized controlled trials and everything else, it has shown that the effect on hemiplegic CPs, on stroke rehab in adults, everywhere there is a significant improvement. So your physiotherapist must be told to do this, because many of them don't do it. They just do this, tightness, stretching and all this kind of thing. And there are many other things which have been done. There have been magnetic stimulation of the normal side to help recovery, because normal side magnetic stimulation inhibits the normal side. So that's another way of doing it, but that of course is still in the experimental stage. So CIMT is the main thing. What else should he do, especially if he's got a toe like this, if he's got upgo? Splinting. It's called AFO, ankle foot orthosis. So physiotherapy, CIMT, ankle foot orthosis. What would you tell the mother? Will my kid walk? You can say. Will my kid walk?
He won't be able to walk.
My God.
Mother, I won't reveal directly.
No. Because you should not reveal, because you're giving the wrong message. Anybody who sits by 2 years always walks. He sat by 2 years. If he doesn't sit by 4 years, he won't walk. But he's already sitting. So he will definitely walk. A hemiplegic almost always walk. So there is no problem. He's walking. Of course, you should also start speech therapy and all this kind of thing. What is the usual etiology of hemiplegic CPs and when does it occur? Is this the usual history you have in newborns with a hemiplegic story? Go on, give him the mic.
Mostly newborn with hemiplegic CP present with one side seizures are mostly, sir, due to perinatal seizure, stroke.
And after that what happens? You find the hand to be weak?
Hand will be weak, sir, due to stroke can cause forward sometime neuronal.
So most patients will have a hemiplegia at birth?
Yes, sir.
Well,
Mostly present with seizures.
actually no. The answer is no. Usually hemiplegic CPs present later.
But at time of birth, they might be present with seizures, sir.
Yeah, so if in 70% of patients, the hemiplegia occurs in utero. So at birth, nothing happens. They are normal. In those who have patients who have Neonatal stroke, yes. Seizures are the most common, but not a hemiplegia. And why not? If I have told numerous times, why don't you have a hemiplegia at birth? Whenever you have weakness at birth, you must always look at peripheral. Optic brachial plexus palsy. You will almost never have weakness at birth in a hemiplegia because it's bilateral innervation, and the only thing which has unilateral innervation is the hand. And the hand is not used at birth. Hand gets used by the age of 6-7 months. That is the time when you realize that you have a hand preference, or he is not moving his side very well. So usually patients who have hemiplegics, they usually present either at birth only with seizures like you said, or later on with hand preference or using one hand less. Okay. I think we stop here. Any questions, anything at all?
Yeah. Thank you so much, sir, for this very enlightening session. And we sign off with the reminder that the next broadcast will be from Kachikamakoti Child Trust Hospital on the 11th of Feb, 2:30 p.m. onwards. See you there.
Okay. Thank you.